Good afternoon. I'm so glad to see all of you all here. And on behalf of everyone here at the Center for Brain Health, welcome to Frontiers of Brain Health, where we take a deep dive into the most exciting new developments in brain research. I'm Dr. Jane Wigginton, and I'm the Medical Science Research Director here at the Center. And I wanted to fill you in on a few things. We'll have a few minutes at the end to answer some questions. So if you're visiting with us virtually, please use the Q&A function. And if you're here in person, please have your questions ready to ask. We'll get to as many at the end as possible. And I wanted to let you know also, as we heard earlier, that this is recorded. For those of you who don't know much about us, the Center for Brain Health is a cognitive neuroscience research center of the University of Texas at Dallas. And super importantly, for the past 3 decades, we've been leading the scientific quest to measure and improve brain health across the entire lifespan. Because here's the bottom line. Optimal brain performance is the new, most important frontier of human potential. And now, I'd like to introduce you to our speaker, who is Dr. Mustafa Husain, who is an adjunct professor of psychiatry and neurology and a fellow at the Peter O'Donnell Brain Institute at UT Southwestern Medical Center, as well as a distinguished adjunct professor of psychiatry and behavioral sciences at the Duke University School of Medicine. He specializes in 3 different areas. Most doctors only specialize in 1, but he specializes in 3. And it's neurology, psychiatry, and geriatric medicine. He's been on study sections with the National Institutes of Health, and he's published over 200 manuscripts in his distinguished, wonderful career. His research interests include general psychiatry, aging and geriatric issues, new applications of lead placement in electroconvulsive therapy, and novel treatments of major depressive disorder, including magnetic seizure therapy, transcranial magnetic stimulation, deep brain stimulation, and vagus nerve stimulation. And so without further ado, I'm going to turn it over to our distinguished lecturer.
First of all, Jane, thank you for a very humbling introduction, very kind of you. And thank you, of course, Sandy, for inviting me. It's a pleasure. It's amazing just to be in this place. This is only the 2nd time that I've visited here, okay? First as an audience, and now as a speaker. So amazing. I don't know if you guys noticed. Whoever designed this, these neurons, just as if your brain is right up there. Thank you. And the contributions that the Center for Brain Health has done to the well-being of our brains, not just locally, regionally, but honestly at a national and a world international level. So thank you for all of us. I do not want to forget Bonnie and her team made my trip so beautiful. So without further ado, I will get back to this, where I will be talking about neuromodulation, the new era for the treatment of depression. Very interesting topic, but a very broad topic, and I will not be able to cover everything. So my understanding is, of course, Dan and we were there for dinner last night. So I have modified my talk based on the audience. I will be discussing some of the studies that I've been involved with. And the part of the reason is I want to educate my graduate students, my junior faculty, how to evolve and develop your careers. That's one part of it, and that will be covered in the first part. And then I'll be discussing other aspects of neuromodulation. These are my disclosures. I've been funded from NIH, NIMH, National Institute of Aging, and others NARSED, Stanley Foundations, DoD, and the list goes on and on and on. I've been consultant with the industry too. So most of the support I got was primarily for research purposes. These are before, I mean, this is generally the slide we put at the end, but it's critical to acknowledge the people. I mean, to do this kind of work, you truly need a village to work together. The other message that I want to leave, and I'll show you, it's truly, this kind of work is a multi-center work. You cannot just do it by one person or one center. So it's critical for all of us to come together and do this kind of work. So here is a list of some of the people from UT Southwestern. Of course, John Rush and Eric Nestler were my mentors in that respect. Sean McClintock is not here today, but was my right hand, was my pre-doc, was my postdoc, PA. Now he is an endowed chair, full professor at UT Southwestern. So I take a lot of pride in mentoring, and that's what I'll try to do today too. There are others, the Duke group, Sarah Lisenby, Holly Lisenby was the director at NIMH, okay, and spent a lot of time, is now, Sandy, she has moved to Arizona, and she is the founding dean of the new medical school in Arizona. So it's very interesting. There are others, of course, Rich Weiner, a biomedical engineer, MD, PhD in biomedical engineering. And I'm mentioning these because I learned from these people how important, critical it is for neuromodulation for all of us to work together. All right, why depression? So depression, especially, is millions of people across are affected by depression, okay? It causes one of the significant functional impairment, all right? It is probably one of the second leading cause of disease burden worldwide, all right? And clearly, highly economical burden on the society. That's why over the last centuries and others, we did not pay as much attention because of the stigma. But it's important to pay attention to it and treat it because it's treatable and we can do something about it. So, what's treatment-resistant depression? Treatment-resistant depression is basically those who our usual treatments, and I'll come to that, do not respond well. The big study, which was led by John Rush here, I was part of that. I was one of the PIs for the Dallas Center. Almost 1/3 of the people do not respond to any form of treatments provided, okay? So what do we do with that? A combination of treatments. That's where my focus today will be talking about the other form, innovative forms, that treatments that at least we need to start thinking about and look into it. So I'm dividing my talk into 3 parts. I don't know if I'll be able to reach the third part, but part 1, ECT, has been around for such a long time. And why don't we then do it? I'll talk about the core trial and the PRIDE study and eventually end up with magnetic seizure therapy. That, Dan, is meant for our graduate students. How do you build up your careers? How from one study you make the next study, the third study, the fourth study. UTD has done so well. There's no question. And some place like BrainHealth, they truly are. I was talking to us last evening. You mentioned UTD, and people say, wow, what a great place to be and what a great work to do in that aspect. And it is, again, credit to people like Cindy and others, and people like you, philanthropists, the city-involved metroplex people who are devoted to move this forward. And if I get a chance, then I'll talk about this. So here it is. Here's the dilemma. If you go back last century, majority in the beginning, the primary form of the treatment was psychotherapy. And I'm a biological psychiatrist, but I do believe in psychotherapy. Psychotherapy, especially in combination, plays a major role in the well-being of the patients. All right? But does it solve everything? Not necessarily. And we really need to move. If you think about, in the 60s, we moved to pharmacotherapy. Why? All we learned when I was a resident and a fellow, that it's neurochemical imbalance. That's what causes depression. Epinephrine, norepinephrine, serotonergic, the receptors. But that's a downstream effect of depression. The real effect, and I'll tell you why it is important, it is because brain is not necessarily a chemical. It is a digital or neuronal. The neurons are the chips. We started to understand it. And how do we modulate those neuronal connections so that A, we recognize what is normal and what is not so normal, and how we can help those in that. And I'll talk a little bit about it in my talk. So, is this concept new? If you look historically, the Greek mythology, you find out there are different parts of the brain which are connected. All right? Even one of the, it's a nice book that I read. So they, of course, didn't have the technology to look into in depth, but they traced up, or at least marked, that this is, if this is the part of the brain which is responsible for friendship, the kinds of friends that you have, then it is connected to love. And I don't know why we didn't pay as much attention, you know. And we started thinking more and more and more that it's not just one part of the brain. It is the whole brain connected to each other. With, of course, advanced technology, with the nodes, UTD, UT Southwestern, others, with neuroimaging, how much we can do now. How much we can identify the nodes. Nodes, neuronal, how they're connected with each other. Okay? And how do they talk to you? There's, of course, DTI, that you have started understanding, looking into it. I very quickly moved from neurochemical to neuromodulation, neuroplasticity, because I can spend the whole day talking about the theories and so on and so forth. But I want to do, this is the topic, the new era, neuromodulation in that respect. All right, let's step back. Quickly talk about ECT. I'm not going to spend too much of time, but you know, ECT is not new. Even Hippocrates talked about convulsions helping mental health. Way goes back, all right? Then Wagner induced malaria high fever to cause seizures. So we knew that seizures has something to do with improvement in mood. There was no distinction at the time, thought disorder and mood disorder. I'll come back to that. Then, of course, then came insulin coma. You know how it worked? Hypoglycemia, there used to be insulin wards. Hypoglycemia will cause seizures. I don't know how many of you remember the movie A Beautiful Mind. Dr. Nash, who got a Nobel Prize, received insulin therapy treatment. So there was something to it that we need to look into. And of course, in the late 1930s, ECT, electroconvulsive therapy, came into being. And in 1940, close to that, it came to United States. In New York. You know, New York is always first. So this is one of the earliest form of ECT. All right? This little box is just an electrical box providing the treatment. All right? The doctor actually just stands there. It is the nurses, the psychologists, and other people who are responsible, not only just for the treatment, but to manage the patients. Interestingly, the table that you, by the way, there was no anesthesia, there was no muscle relaxants, and that led to many complications of ECT. That is one of the main reasons. Even today, it is not the front line. Okay? What were the indications? How was it used? Severe treatment-resistant depression, psychotic depression, melancholic depression, atypical depression, even refractory bipolar, schizophrenia. Initially, it was primarily used for schizophrenia. Of course, later we got the neuroleptics, and many of those people benefited from those, and we didn't needed that. But that's the kind of acute catatonia or NMS. It's probably one of the first things that we need to look into. So this is from Kaplan and Sadek, pretty much the Bible of ECT. And this is a statement that ECT is one of the most effective somatic therapies available in psychiatry today. As if we are waiting. Tomorrow, something will be there to replace it. And why? Why? Because of this. The media has never accepted ECT. This was a beautiful movie where Jack Nicklaus did an excellent job on One Flew Over Cuckoo's Nest. And we have never been able to come out of it. I don't think we can ever, this will become frontline. But I will show you the data, and this is the data now that I want to share with my postdocs, with my junior faculty. How you built up your career. How, I mean, clearly if you look at it, there was evidence it worked. So one of the few things which happened, once the medications came on board, one of the major problems associated with ECT was cognitive issues, memory issues, okay? That's why nobody wanted it, all right? And over a period of time, I worked with Rich Weiner and Harold Sekheim, that we looked at what type of ECT. Bilateral, unilateral, non-dominant, bifrontal, and there are many others. Why? The reason, first of all, we found out that unilateral, which causes much less cognitive problems, can be as good, all right, in that respect. This is the reason. Bilateral on the right side, this is computer modeling. The electricity is all over, okay? And that's what causes all the problems in that respect. Bifrontal, as you can see, just in front. But this is right unilateral, much less. That's the important. So today, if I stand here, I advise that please, if you have to get it, and there will be times, then you should go with right unilateral, okay? Not bilateral. You will have other issues. So, is it so bad? Does it cause deaths? The mortality rate associated with ECT is as little as what happens in childbirth. Interestingly, isn't it? But you hear it all the time. On the media, in the movies. Okay? One of the things is, of course, you have to give a course of ECT. It is not one treatment. It is a whole course, and I will discuss in my studies. So another major problem is, fine, acute depression, fine, catatonia, you fix them. But the relapse rate associated with post-ECT can be as high as 80% within 6 months. So what are we supposed to do? Are we going to buzz them all through? We cannot do that. And I'll come back to it. But for my postgrads, for my junior faculty, this data was available for decades. How do you build up on that? And that was our first study, major multi-center study called the CORE trial. Consortium of Research in ECT, UT Southwestern was part of it, Mayo Clinic, and other centers. This is the design, and I'm going to go quickly depending on my audience, okay? And of course, this is recorded, so the postdocs and others can look at it. We provided ECT, bilateral ECT. We wanted the most effective form of treatments, okay? Then once they responded, we randomized it into nortriptyline and lithium and continuation ECT. There was a protocol, once a week after they're done well, once every 2 weeks, after a month, and then eventually up to 6 months. Let me show you the data, I hope. So this was considered as one of the largest studies ever done in ECT. It's very difficult, Sandy, to do this kind. And the funding. I mean, that's why multi-center becomes critical. Okay, you go with the group, go with the concept. So there was 531 subjects. At the end, about 90 were randomized to receive ECT alone or medication alone. What did we find out? Look at this, that people who received ECT, acute phase, 87% of the people were responders. Amazing. How many treatments can provide that? Very few in that respect. And I published this, that within the first 3 treatments, acutely psychotic, acutely suicidal, acutely melancholic, got better. It was interesting how these insurance companies work. When we published this, we started getting a call. Why don't you do it more often? Because the families disagree. Because the media will get after us. We don't want to do that. Anyway, so why did it go away? Manny, did I do something? I still have it here. Anyway, I can continue talking and no limited time in that respect. So just unbelievable outcome. But the key findings of this study, Sandy, was that what happens afterward when we did maintenance ECT, and what we find out was at the end of 6 months, there were more people in maintenance ECT who relapsed versus those who were on medication. Now, people like us, or Max Spinks, who was considered godfather of ECT in this country, from New York, we were furious. How come this happened? That a treatment which worked acutely didn't do as well, okay? But here is the message for my junior, young faculty, people who work here. Funding is tight. You never give up. You continue. Actually, sometimes a failed study leads, there's a blessing in disguise. It raises more questions. And when you raise more questions, you get funded. If it was a successful study, we would never have been funded in that respect. We got another large, much larger multi-center trial called the PRIDE trial, Prevention of Relapse in Depression with ECT. You know, these names are so important for those who apply for grants. And John Rush was a master of it. The star D that we all remember. So those are the kind of things that we did. All right, we can continue doing that.
Not yet. We're still fixing this.
Okay, no problem, no problem. Is it okay without slides? Yes. All right, I'll do my best. And I'm not going to show you the slides again. So we did the PRIDE trial. So what is realized? Look, the majority of the people are the people who are, you can do your trial. Honestly, many, especially the basic studies. And some of the trials we did are in glass houses. Inclusion criteria, exclusion criteria. What about the real patients? What about the real people who are present here? I'm interested in my well-being of my brain, healthy brain. How can I do that? All right? Anyway, we did this. For the first time, we realized you can't depend on one. So we combined it with meds, number one. Okay? Plus, you know, the question becomes that you provide that treatment not by itself. Okay? So we tried that, and we did find that combining ECT, right unilateral, because if you continue with bilateral, they're so confused, cognitively affected, they're not going to get it. All right? So we did that, and we find that out. But my friends, I'll tell you, even then, the word shock, ooh, we don't want it. Okay? It will never become first-line treatment. And we realized it the hard way. Then what do we do? That's where, and I would give the credit to Dr. Holly Lisenby and some of the others. What are other ways, going back to the history, that we can modulate neural connections, connectivity, okay, then can produce similar effects like ECT without causing without causing the cognitive effects, the other effects of ECT. All right, and that's where magnetic seizure therapy came into being. All right, we did a trial, CREST trial, the clinical efficiency of magnetic seizure therapy, CREST trial. I gave that name, by the way. Not Colgate, it's CREST, okay? So very interesting, very interesting. And obviously, the goal was, it was not meant for garden variety depression. It was meant for a much more serious form of catatonic, melancholic, psychotic, acutely suicidal depression. I wish we can get to our first video clip. Maybe it was the fifth. So the work was done first in animal models. You have to do that. We tried in rats, mice. You can't provide a magnetic treatment. Then we tried in monkeys. So our basic model was monkeys. And I'm not going to tell the stories about monkeys, but what it taught us, that it can be equally effective with minimal, honestly minimal cognitive effects. That's the beauty. That's where we see the field moving, magnetic rather than electrical stimulation. It was the cognitive effect. That was the main thing regarding that. All right? So the first treatment we did, again, it was 7th or 8th treatment. I was shocked, not electrically shocked, but what happened? The patient woke up and basically asked, Dr. Husain, is my treatment over? You never see that with ECT. They're confused for a long, long time. Okay? The whole day we asked them. All right? And if they received as many as I described from the other study, a vice president of a bank may not be able to balance their checkbook. Okay? These are realities, and we need to address those with our work, with our research. All right. So, first, I wish I could show some of those slides. Cognition, we compared monkeys with humans. A lot of cognitive testing, which was done. And any guesses? Both them. This was proof of concept studies. Who did better? There you go. So there are a lot of automatic functioning. They are on the grids. They are picking up the choices. They are getting a reward, the juice. And now I'm not talking about they were compared with high-level intellectual, poor postdocs, pre-docs, who were doing the same test. But the monkeys did better. All right. So, but we were able to figure it out that, look, we can do this with magnetic without causing that level of cognitive problems. All right. Our next step was, now we know ECT is highly effective. You remember? 87%. Can MST do that? Can we really be comparable? So we did a comparative trial. That trial was funded by Stanley. Then I'm bringing these. I know the funding environment is so difficult right now. What do? You go to some of these foundations, okay, the MDA. You go to DOD, still have deep pockets, okay, department, and they do fund quite a bit. But their interest is mostly like PTSD and others. And there is a role of some of these for that matter, okay. Trial was done, proof of concept, initial study, and we were delighted to see that maybe not better, but almost close to, as a matter of fact, statistically there was no difference. The thing which was different, was remarkably different, I've already gave it, was the cognitive effects. Almost none associated with magnetic seizure therapy. I would have shown you the data in that respect. Why? Because amygdala, hippocampus are deep-seated. Electrical shock basically hits you all over the place, all over the brain. But your very specific areas that you pick up, that you go to, does not. With magnetic, you can really focus it, okay? I think it's a good area to invest in, okay? Time will tell. So Again, I'm not going to tell you that MST was so much better than ECT. No, we lost to ECT in terms of efficacy. But in terms of side effect burden, we were so much better, okay? And obviously, this is something very new, okay? And maybe one day we can refine it, define it, that it will become a better, or if not better, even if it is comparative, I think it will be much more acceptable and it will be useful. All right. All right, no problem. With your permission, I'll keep on going. So let me change gears here. What about other forms of magnetic treatments? Why? In the first place, I think I've already bring forward that these treatments are, at least in terms of cognition, magnetic stimulation does not seems to affect the cognition at that level. One, TMS, transcranial magnetic stimulation. One of the first studies which was done, neuronetics trial, industry-sponsored trial, we were part of it. Actually, the paper which led to the approval of TMS I was the second author on that paper. Holly Lisenby is the primary author on that. And once they get approved, then it was approved for only single failure, not for TRD, not for multiple failures of medications, all right? But once approved, off-label use. So I want to leave a word of caution. And the word of caution is, it is useful, it is effective, okay? And that's where the field is moving. We are neuromodulating in that respect. But we still need to learn a lot. And that's where your support, or the support in this area of neuromodulation is critical, okay? How do we find out the right mix with medications, without medications, in that respect? TMS is being used for everything. It's being looked into every area. The VA is very much interested in TMS for PTSD, okay? John Hart was involved with the study. It didn't pan out. And the part of the problem with that is that PTSD is very complex. Not every person has the same injury. Not every soldier get affected in the same way. Plus, I mean, my hearts go out to them. There's so much drugs and alcohol and other issues that you can't just find a solution to all of them. Yes, ma'am. You had a question? All right. So it is being used for the whole spectrum. For neurological purposes, stroke rehab, okay, in combination with PMNR, has value. There's some good work. Chronic fatigue syndrome, OCD, and of course, I would have shown you by different targeting, by different coils shaped. It's interesting. I mean, we take all the credit. We forget about our biomedical engineers. Wow, it's amazing what they do. Oh, almost my talk is done. Well, I'm going to rush. Manny, can you just move on? Just get to the video. But I'm keeping an eye on the clock. This is beautifully placed. Barney, you don't have to do anything. I'm watching it. Keep on going, keep on going. That's what. Move on. Just to the first video clip. This is, of course, we talked about it. I think I covered quite a bit. This is the first study. Okay, this is the pride. And then what do we do? MST. Can you go back one slide? So why magnets? Because magnets is very, very focal. Okay? It penetrates not as much as compared to electrical stimulation. Much better control. And then the goal is to affect the limbic system, the seat of human emotions. Next slide. All right, I think I can do it. All right, this is my Vicky. Vicky was so cute. She was so good. You know why she was named Vicky? She bit me. And we used to call her Vicious, but we wanted to kind of tame it down, so she became Vicky. And this is our postdoc. All right. And these are kind of tests that many of you are familiar with. We also did pathological. Oh, I'm not going to talk about it. You used to postmortem and look at them. Neurofibrogenesis, mossy fiber sprouting for that purposes. And yes, ECT, my colleagues from biomedical engineering, this is our initial, you know, you can get all these boosters from Home Depot. That's how we started. That's how my young colleagues need to think, okay? These are the coils. Look at this, homemade. Because, you know, if I put that coil, it will not be able to reach it. I'm going to rush. See if this works. Manny? I'll skip that. This is the patient, 6th or the 7th ever, who got MST. And the best part of this clip is that she woke up and started talking to you. Amazing. I'm going to skip all of this. This is how we evolved. You know, Sandy, where the School of Biomedical Engineering is top-notch at UTD. I mean, they produced VNS, after all, the work they've done. So how we collaborate with them is key. I'm going to keep on going. This is the orientation difference, so much better. My apologies. Why the people, this is ECT, this is MST. And the reason is ECT, the complete suppression. This is only 4 lead, okay? But we did 16 lead montage. And you see with MST, it doesn't completely die off, all right? So we showed that it works, okay? Then we did the CREST trial. Now the industry jumped in, okay? And you can see the difference of homemade treatments and the industry made. Beautiful. Can we show this video, Manny? That will tell you where we are with the field. Full screen, and then you can be. Sorry about that. Go down. Yeah. Yeah. Run it. ECT is one of the most effective treatment available in psychiatry today, especially for severe depression.
Typically, the seizure lasts about 30 to 45 seconds. The whole thing, start to finish, is about 5 minutes. And our patients will generally have 10 to 15 treatments like that.
It's very common with ECT for people to become increasingly forgetful as they move along through their treatment series.
If you could copy this picture in the space below, to the best of your ability.
The hope is that with MST, the short-term memory issues that are very common with ECT either do not develop at all, or if they do, are much milder.
The CREST trial is a comparison between ECT versus MST. We are the only place right now in the United States we are doing any MST studies or trial.
Once we are ready to begin the procedure, we get the magnetic coil out, okay? And this will have already been measured beforehand so that it fits correctly and we know where the device goes.
This is MRI clicking.
And that's it.
Magnetic.
Once the seizure is actually occurring, we can monitor the progress of the seizure by looking at our EEG monitor here.
The acute series with MST is the same as with ECT, so patients are coming ideally 3 times a week for treatment.
And the patients as well as the families will be a lot more comfortable in coming forward and getting the kind of treatment which can help them not only short term but hopefully for a long term. I'll try to wrap it up because I want to leave time for Q&A. Now, let me move on. What are the other forms of neuromodulations? Next, let's see if this works. TMS, again, is nothing new. It goes to 1906 before, and this is Thomson, 1910, who himself gave TMS, okay, and had some neurological feeling, like he could see. So he figured out that it does causes neuroplasticity. That's the value. Why we didn't use it, why, how does it work? I've kind of explained, okay? The magnetic field, the circle affects the brain, and in this respect. One of the things to keep in mind, and again, Dan, the TMS, the depth of TMS stimulation is still, we are still struggling how deep it can go. This is one of the earliest commercial, the neuronetics model. You know, it looks so nice. Your dentist chair, you sit down there, 45 minutes, getting your TMS, all right? The results, there was efficacy. There's no question about it. But to what extent? It's an issue. And is it sustainable? Depression is a chronic illness, and we need to. There are other coils, deep TMS. Some evidence that it works in OCD. We have to learn a lot. Before we jump onto the bandwagon, we need to really learn it in that respect. This theta burst is something that I would tell my students is the way to go. Because the regular TMS, 45 minutes, you can't target it. It's very difficult. This is home use TMS. This was a whole issue on brain stimulation in the American Journal, and primarily focusing on TACS, or electrical stimulation. Very simple, easy to give, very cheap, clearly causes neuromodulation, something that you don't need multi-million-dollar grants. Okay? Should be encouraged to our younger. Learn the basics before you jump into treatments. Anode, cathode. I'm rushing. I realize that because of the time lost. VNS, of course, it is useful in the different types of VNS. One is surgical. The one developed here at UTD is of course auricular, the one that you see in external. We did the second patient of VNS, the surgical one. And any surgical procedure has risk associated. So we have to be careful. And there was a New England Journal paper, psychosurgery is nothing new. What did they used to do? Trephining, okay? And this goes back centuries. Moniz got his Nobel Prize for the work he did with psychosurgery, frontal lobectomies. Okay, that Freeman did that in patients without even anesthesia. We should not forget it. By the way, it's in public domain. I'm mentioning that Eunice Kennedy, one of the daughters of Kennedy, got frontal lobectomy. Okay, so there is value to all of this, but we need to learn more. TBS. This is from Parkinson's disease. This is a patient who received deep brain stimulation. And when it was stopped, she became tearful. Okay? And once it was restarted, she was feeling fine. So we learn there are specific parts of the brain which are connected and how we can utilize. By the way, it's not easy, as you can see, the surgery. And these are the leads being put in. Can you recognize the hands? No, I'm kidding. Done by neurosurgeons. So the brain, the way when you are petting, you feel like a compressed sponge, and you are trying to reach the target with the neuroimaging. Very interesting. This is how it looks eventually, all right, on MRI. Future. Now, so yes, I've already kind of discussed there is extreme value, utilization from the past to the present, and maybe what in future. But we have to be careful. What happens with these kind of technologies? Everybody wants to jump onto the bandwagon. There's so many different types of brain stimulation technologies, which are good, which are not so good. We just don't know. Okay? These are some home devices. Okay? Of course, optogenetics, high potential. All right? But how do you create a rat model of depression? All right? There's learned helplessness. Nevertheless, it's not the same. I am very excited about ultrasound, focused ultrasound, because it can be very focused, it's very benign. Right now, technology is you need huge. But Sandy, that's something to invest in. That's something to invest in. UTD, Brain Health Center, can become the leaders. Utah, University of Utah, are the ones who is leading. I was actually supposed to do a trial before I left. And of course, how can you not mention our dear friend Elon Musk? Neuralink, they're already placing chips. Now, right now, it's motor. People with stroke, that their motor function is lost, they can do that. My concern is, my ethicist friend, what if we started putting ideas into their brains? Everybody will be the same personality, same everything. So there's a lot to learn before we move there. There are other types. By the way, all of these, I got it online. All kind of brain stimulations that can be. There's one which the students used to enhance cognition while taking their exams. This is from India. Okay? Hey guys, we need to do some very, very scientific work before we jump on this. So at least I finished it, but to let you know, this is the reason I moved back to North Carolina. This is my grandson. All right. Thank you for your attention. Sorry.
Thank you so much, Dr. Husain, for being such a fascinating, masterful presenter, both with and without your slides. And so now we would love to take some questions. Yes. Steve?
So what kind of cognitive therapy, if any, is used pre and post these kinds of stimulations? Because I'm wondering if there's an opportunity for us with some interventional training to build resilience before someone goes through these kinds of, harsher treatments. And then do we have any evidence that building that kind of resilience leads to better results on the back end?
Excellent question, sir. Okay. My disclosure is I'm not a cognitive behavioral therapist, and you need people like you to start studying. So we did combine. One of these would not work by itself. And the primary form of therapy which was used was CBT. It doesn't work with ECT, but they just cannot process it. With TMS, now there are quite a few protocols which are combining. Now, in my opinion, these patients come to you on a daily basis for 45 minutes. Irrespective, you are sitting with the technician, and believe it or not, there is supportive psychotherapy happening right there. It is very difficult to separate how much is TMS, how much it is just interaction with the therapist. How do you create a sham therapy versus a very? But I honestly believe that there is a major significant role of combining psychotherapy with some of these brain stimulation. Thank you for your question. Yes, ma'am.
Yes, go ahead.
I'm sorry. I'd like to take a conversation from that thing, and that is, I heard Dr. Portanian, who does, essential tremors and Parkinson's. Is there a way to identify, or is there any research going on to identify which patients will do better, as opposed to which treatment is better, but which patient will benefit most from which one of these tremors, not tremors, but one of these procedures, because everybody is different.
Yep,
And so the
absolutely.
question is, how do you deal with
Decide
that, or have we? Because to me, that's an ethical issue. We shouldn't be doing it on
Absolutely.
people who will not benefit. We should
Yeah.
be doing it on those
So-
that will be most benefit.
Very important question. Predictor of response. I'll tell you who is the expert in this room. Kathy. Kathy, who's a neurologist, had done a lot of these work. And maybe, Kathy, would you like to respond to that, or do you want me to?
I'm going to let you.
So you have to pay a price if you are the speaker. So it's a very important ethical issue, ethical questions. And I will broaden it rather than just sticking to Parkinson's. Okay. Brain devices, irrespective, especially invasive brain treatments, like deep brain stimulation, like vagus nerve stimulation, are not benign. VNS, once it's put, it's forever. All right? You may remove, but the leads still stay there. The others associated risk. Then you move on to deep brain stimulation. At least the leads can be taken out. But when you are going in, I showed you, I didn't go into the details, there ought to be some effects. Extremely important ethical questions, medico-legal questions, how much we really dealt in informed consent. I had a shoulder surgery. This was thick consent. I signed it. And really, that's why I made a statement earlier. There is so much to learn, not just from the science perspective, but psychosocial before. And honestly, people like you are the ones who will tell us, look, we are dealing with brain. We are not dealing with orthopedic surgery. We are not dealing with, you can mess it up forever, all right? And we need to address those. I don't know if I answered your question, but that's the best that I can think of.
Oh, you did a great job answering the question, and I want to thank you for your questions today.
Can I ask one more?
Sure, of course.
Let me just ask one question, and not a long answer, but what would you think of the outcome measures improving, like people that are developing ways to look into the eyes for depression that are tracking it? Because so many of the outcome measures of are they working are just, I think it's working because I want to feel better because you've just done a lot to my brain. What do you see as the advances in improving outcome measures of these treatments?
Very important scientific question, very critical, and we need to learn a lot. Now, looking at the eyes reflects what's going on in the brain in many ways, okay? So some of the work, earlier work in schizophrenia, sarcastic movements of the eyes is important. Your question is outcome. Does what you look at reflects truly the outcome? I have looked at some of the studies, but they are still very limited. And if you look at the spectrum, some are very positive, some are not so positive. So that's another area that we have a long way to learn, long way to understand how this is our roadway to the brain.
We've got a BrainHealth index. We'd love to use it for work.
Yes, absolutely, absolutely. We are out of time, and I know there are a lot of questions, and I apologize for a little bit, but I tried to cover as the most as I could. I like that video clip. Thank you so much. You take care.
So, lifelong brain health, that's our shared mission. And I want to thank Dr. Husain so much for bringing us this fascinating information about treatment-resistant depression and sharing with us so many different opportunities for treatment, both now and also in the future. And to our audience, thank you so much for joining us today.
If you want to stay and talk one-to-one, I'll be happy to.
We hope to see everybody again on September 26th when we have Dr. Gopal Gupta, who's professor of computer science here at UT Dallas. He'll be speaking about automating slow thinking AI. So that should be fascinating as well. So thank you all for spending time with us today, and have a wonderful afternoon.